just that relationship and how well they felt their child was cared for and they were cared for some reason means something to me. And it gets me coming back to my job day in and day out.
Welcome back to PedScript. I'm Zach Hodgers, a pediatric ICU fellow from UT Southwestern in Dallas.
And I'm Alice Shanklin, a critical care fellow at Children's National in Washington, D.C.
So Alice, what are we speaking about today?
Today, we're talking about long stay and complex care patients and really going to dive into what the structure of the primary intensivist model is, what are the pros and cons, and how are units even staffing this?
Right. This is a complex problem, and our divisions are already very short on resources with the large number of critically ill patients. In this episode, we really take a deep dive on how we operationalize this. So Alice, who are we speaking with today?
Today, we've got Dr. Jeffrey Edwards and Dr. Erin Gordon. Jeff Edwards is an Associate Professor of Pediatrics at Columbia University and a pediatric intensivist at Morgan Stanley Children's Hospital. He, for years, has been really researching this topic and is looking to expand more into the primary intensivist side.
And Dr. Erin Gordon is an Associate Professor of Pediatrics here at University of Texas Southwestern and an intensivist in the cardiac ICU. She's the medical director of the inpatient developmental care program and very passionate on this topic of primary intensivists.
Yes, we are so lucky to be talking with both of them. Let's get right to the episode.
Erin, let's get granular and think about what exactly a primary intensivist is. So will you tell us what services do primary intensivists offer to patients? Which patients are eligible in our ICUs?
I think in my mind, the easiest way to explain what a primary intensivist should be doing, it's encouraging and advocating, encouraging better communication, encouraging family participation, advocating for the progress of a patient within the ICU, advocating for the family, attending the family meetings or multidisciplinary meetings, as we are going to change the name of here at CMC, and really being with the family during their journey and whatever journey that may be. I think more times than not, from my own personal experience as a primary intensivist, it's during the end of life care or the withdrawal of life-sustaining efforts that I think my role is most impactful because of the relationship that I have formed with the families over the time. You know, in the cardiac ICU, we have our patients for quite some time. And when they come back to the ICU, we oftentimes become that primary intensivist again. Even if it's not been within 48 hours, we just kind of take them on because we have that relationship with the family. The question of who should receive a primary intensivist, I really think it should be all comers. Because what if it's the patient who's been in the ICU for 2 days, but is very complex, and you see that they would benefit from having a patient advocate or a family advocate in the primary intensivist? And I certainly think, some of the papers exclude those with language barriers, but I think sometimes those are the most delicate patients that probably need the most advocacy. I would take kind of all comers. Here we do anyone greater than 14 days, but recognizing those whom are heart failure, transplant, single ventricle, we know pretty early on that they're going to be in the hospital for quite some time. So we'll consider them eligible sooner than the typical 14 days. I think just piggybacking on what Jeff said about the distress that can come along with being a primary intensivist. And I think that comes along with who you are and the relationship that you've formed, and also your willingness for that time commitment. When we think about how much time, is it a 1-hour meeting every week? And I think that really depends on the clinical status of the patient. If the patient is not doing well, I think that I'm at the bedside quite a bit and really become more involved in the, not minute-to-minute medicine, but the day-to-day. What does today look like that looked different than yesterday? Just kind of to assist with the primary care team during that time.
I think that's really helpful. And it's really easy to see when you have that patient who's born with a single ventricle with complex anatomy, they're going to be here for a while. I don't really need to wait 14 days to decide this is going to be a long stay patient. Jeff, I'd love to hear your thoughts. Thinking about the general PICU side, maybe it's a medium to large size ICU. They have 30 to 40 beds. How do they typically decide who's going to be deemed a long stay patient? They're going to receive primary intensivist. And maybe how do you choose who is the primary intensivist?
I would say ideal is, as Erin said, for all patients. There actually are PICUs out there that every patient, no matter the length of stay, receives primary nursing. But not every single ICU has the resources to provide these sorts of continuity interventions. So I think it's upon each ICU to take a honest look at what they're capable of doing and what they're not capable of doing, figuring out where their limits are, and then using the resources they have the best they can for their patients. Really what I would advocate for, as opposed to a standard number, I think 14 days is very standard, 28 is very standard. That is that places really just have predetermined criteria. And if the resources are such that not every patient can receive it, then who the ICU thinks needs to be prioritized, that gets decided ahead of time. So there aren't really biased, even potential for biased decisions about who gets it, intervention, who doesn't.
Mm-hmm. That does sound important, making sure that it's equitable in terms of which patients receive a primary intensivist.
And I think just piggybacking on his capability comment, I think when the families are given the option of whom they can choose from, say there's 10 intensivists and they have the option to choose from any 10, within those 14 days, they may have met 2, they may have met 5, depending on how critically ill their child has been and or how involved the nighttime team is with the patient on their particular call night. And I think when you offer the family the option, at times the chosen provider may be the same. And it's often difficult to say no to a family who really wants to continue a relationship with you as a physician. But it becomes overwhelming to take care of, for primary intensivists at any given time, knowing that the duration that they are often in the cardiac ICU. And so I think in one of Jeff's papers, we read limiting the number of patients a primary intensivist and or a primary nurse cares for at any one given time, I think is very thoughtful in really maintaining longevity within the primary intensivist program.
That sounds like math that can be done, right? How many patients in our population will meet these criteria? How many providers do we have? How many primary intensive spots are there? Do we need to adjust our criteria? Do you two think in building the program that that's the type of thing divisions will be calculating, or?
That's hard to know because not everyone desires to be a primary intensivist. At least that's what I've learned here. And it's historically volunteer based. Mm-hmm. And so even if you have, say, 10 intensivists, but only 5 are willing, and the sheer number, there's 32 patients, then how do you really assign each patient a primary intensivist? So that's where it gets a little bit more challenging.
I think you can, over time, better sort out those numbers. Starting out, it might be a little bit difficult. I think the average primary relationship is not onerous. At least in the general medical surgical ICUs, a long-stay patient's not necessarily going to be there for months and months. But there will be times, and sometimes it's not predictable, where the relationship can be a very long one and taxing one for all involved. So I do think you, as Erin alluded, you have to be mindful of that. And forming the culture of this in an ICU will take time, and figuring those things out take time as well.
Jeff, how do you recommend that a primary intensivist communicate with their families when they're not within the hospital? Is it through the social worker? Is it through the on-call or on-service attending? I think that's where it gets a little more challenging. It's just how do you maintain that check-in or that communication with your family?
So I personally like going to see the family physically, trying once a week. I think, as you know, there are definitely weeks for a long-stay patient where there's not too much going on. And that once a week check-in is sufficient. I think when the family needs or wants to communicate with their primary intensivist outside that, the communication should go through the PICU team. I don't think that families should have cell phone numbers of their primary intensivists, things like that. I think there should be limitation and boundaries, which are good for all, and that the primary intensivist should not be thought of as the personal physician of the patient. I have heard of places doing things like Zoom calls. A lot of people are not going in 5 days a week kind of thing. So using those type of things, and I know places have tried using those sorts of platforms even for just daily rounds to make sure a family is present during the round. So I do think those kind of things could be utilized more and more for the primary role as well.
It seems that each institution is going to have to tailor the services they can offer to the situation they have in front of them. When I hear about all these aspects of a primary intensivist helping improve communication, coordinating care, many of these things seem to be similar to the services provided by a palliative care specialist. Will you help me understand how the role of a primary intensivist is maybe somewhat unique compared to a palliative care physician?
I don't necessarily know if it's different or if it's just additive. The palliative care team may or may not have a relationship that has been established previous to the admission of a patient to the cardiac ICU per se. Say a mom with a fetus with single ventricle anatomy, they meet the palliative care team before, so there may or may not be a relationship established. I think if there's one place to say that there's a difference is that the intensivist often knows the medical and or critical care history a lot better, and so maybe can speak more longitudinally about their medical condition. I absolutely love our palliative care team here at Children's, and we utilize them quite a bit within the cardiac ICU. And so I'm not so sure if there's a difference, but I think it definitely depends on the intensivist with how involved they want to be in those situations. A palliative care provider, we think about it as a person that is able to communicate with a family when their situation is abnormal, which is every patient that's admitted to the critical care units, right? And I think as a primary intensivist, I feel like I often am the same. You want to make sure the family is well. You want to make sure the patient is well, and you want to have those more detailed goals of care conversations. But I think it's definitely dependent on the particular intensivist.
I would agree that I think what a primary intensivist does is very much akin to what palliative care teams do, but to also add a few more things. And that is, and I think we'd all would agree that we're charged with doing primary palliative care in the ICU. Like all ICU caregivers should be giving primary palliative care. But there are places, and when we did our trial here, we didn't have a palliative care team. So there are places that don't have sufficient palliative care support. There's evidence that not every single patient that probably deserves to have a palliative care consult gets one. They have the same problems of handovers to different providers weekly that we do. And I would also offer that having the continuity provided by someone who is in the ICU and part of that culture already, that provides a certain level of clout with the care team that maybe a consultant can't provide.
That makes sense. Honestly, I will say in the cardiac ICU, it's so, and as medicine gets more complicated in the PICU, I can imagine needing to be an intensivist who works there often to really understand for this lesion, where are things going, right? I have kind of a granular question, and I think that you two have alluded to this previously. When I think about patients who have benefited or who would have potentially benefited from this system, I think about big questions like which subacute care facility is the best fit for the family? How are we establishing goals of care? And then I think about more granular things like this is going to be a week-long process to increase the feeds, to titrate sedation and maybe wean it in hopes of an extubation trial. And I wonder if that is something that the primary intensivist would still have a hand in managing, or if that's something that the primary team would reach out to the primary intensivist, touch base about, but own themselves.
I think it's always wise for the medical team to govern the day-to-day management. Oftentimes for patients who have been in I'll use the cardiac ICU because I haven't been in the PICU in quite some time. You know when a patient's had feeding intolerance, you know how to titrate their feeds, you know if they've been really sensitive to sedation weans. And I think the primary intensivist can be helpful in those situations as a consultant. It was tried, 2 weeks ago to escalate the feeds 1 every 12 hours, and that did not go well. So maybe think about doing it daily as opposed to inserting yourself in the day-to-day management, because then you really do feel like you are the primary physician. And that, I think, really muddies the water on whom the family thinks and trusts with the day-to-day care.
I think you said it very well, Erin. Yes.
I wanted to go back just to one thing that Jeff had mentioned about the absence of palliative care teams within many institutions. And really, when we think about our fellows and our own training, say you don't have a passion for palliative care in the way that we think about it as an intensivist, I think that the absence of training during fellowship on communication, difficult topics, and so on and so forth is so important. And I almost wonder if it should be part of the critical care curriculum, like doing some time with a palliative care physician and or learning via the internet on Vital Talk and so on and so forth, ways that you could improve your abilities to have those difficult conversations, because not everyone does a good job with it. And I wonder, Jeff, do you have any thoughts on that, on how we can really make this topic more appealing to critical care fellows, or actually the importance of this topic more appealing to critical care fellows?
Personally, I feel that when we speak to even younger trainees, like residents who are thinking about what they want to do with their lives and maybe even considering pediatric critical care, I feel obliged to make sure they know what they might be getting into. If they work in a tertiary setting, the majority of their patients will have, on the severe side of chronic conditions, and the days of, most of our patients perfectly normal before, getting stricken with something, bouncing back and being perfectly normal at the end, that's not a lot of what we do anymore. And so the trainees need to be aware of that and really want to embrace that as what they do, because it's so important. I think it also is the future of what we'll be doing. And so with that, I try to prepare them ahead of time. So hopefully the kind of people we are training will, as I said, embrace it as part of their career. As far as the training goes, I also encourage trainees to just every single family meeting you can be in to go to and to listen how it's done, so you can pick up, oh, I liked how they did that, or I don't like how they did that. And then as the second half of their fellowship, hopefully they're talking more than the attending, so they can really get practice in there too.
As a trainee, I think of these hard conversations, these family meetings, as almost being like another procedure. And in the same way, as a brand new fellow, an attending wouldn't set me loose and go do an IJ in that patient without me in the room. They would assess my level of skill and give me an appropriate level of responsibility. I see it as I progress through fellowship. My expectation would be that I would take more leadership in these family meetings and have that maybe safety net of the attending over my shoulder to step in maybe when I didn't say something as clearly. So I think as trainees, we should think of these family meetings as opportunities in the same way we think of an intubation or a central line or some invasive procedure, because it seems that when I think about what my attendings spend their time doing, they sure do seem to spend a lot more time having these difficult conversations in these family meetings than they do placing breathing tubes and placing central lines.
And so as we're talking about, I think that third-year fellows, I personally think they should be eligible to be primary intensivists. And taking on that role. I think they're more than likely more than capable, and they should be getting that experience. And I think a lot of them would have the interest in doing it too.
And probably extend that same offer to a passionate fellow that's his first year, second year, really just to learn communication and advocacy and encouragement. I would say any fellow really who wants to take on a primary intensivist and or learn from the program that's may or may not be established and may or not be growing, I think would be really beneficial just to establishing who you want to be as a physician after you leave fellowship.
And with the same concept of the safety net, maybe the attending who's mentoring that fellow, maybe they'll have more oversight early in training versus late in the training, but individualized for that trainee. So we've talked about a lot so far. We defined the problem of those patients with complex medical conditions, the issues that come along with long stays in the ICU. We talked about the evidence that we think that a role of a primary intensivist may have benefit these patients, and we talked about how we intuitively see that at the bedside. I'd like to talk more about how divisions actually staff these programs. Maybe, Jeff, you want to chime in first. How common are primary intensivist programs nationally?
Probably for what we know, maybe a quarter of all-comer ICUs have primary intensivists. Probably close to a third of academic ICUs have primary intensivists. Some of them are more definite programs. Some of them are more ad hoc. Primary nursing is probably more common, has a longer history.
Nice. As you think about the way that you structure FTEs and the way that things are compensated, do you have any thoughts on this, on where we are and where we should be going?
Well, I think Erin and I would allow for a person who does this consistently and does it often and is a primary intensivist for several patients, I personally think maybe that should be rewarded as count as some of their time effort. But if it happens, it's very rare. I think more likely it's just the people who volunteer to do this recognize the ethical and professional imperative to meet the needs of their patients, and so they volunteer. And as I said, many times it's not an onerous role. And also in general, most physicians are used to doing things for which they're not compensated for out of the goodness of their heart, quite frankly.
Yeah, definitely.
And Alice, I think often the reward is the relationship that you form with the families and or the patient. As kind of cheesy as that may sound, and Jeff, everything he said, I couldn't agree with more. And I think when you do a good job day in and day out with your families, that becomes clinically relevant and recognized. You're progressing the patients. You're, forming good communication. Families let you know. And I think that's the biggest reward. And ultimately, it will become more recognized to where you feel like it's impacting your advancement through, say, academic medicine.
And for me, just taking on the role of being naive, when I think about a program that we think is going to make meaningful differences in patient care, it seems that it's not an adequate long-term solution to ask people to do things out of the goodness of their heart, especially if there's a chance that certain individuals are going to take an undue, I don't want to say burden, but opportunity to care for multiple families at one time. It's easy for me to see, especially in the current culture in medicine, someone who's very, very capable getting very burned out. Anyway, not to get us stuck on that topic. So, Erin, you've already emphasized that trainees need really, really good training in communication strategies. And Jeff, I know that you've been a part of studying primary intensivist and your site and maybe other sites as well. Is there any additional training that you like to have primary intensivists achieve before they take on that role? Maybe in a perfect world, what would you say they probably need additional training in?
If it was up to me, I would focus on probably 4 things. One we've highlighted already, and that is effective communication. The second would be complex care. So more and more people are recognizing that pediatric complex care is kind of its own subfield, and there's actually education and training that can be provided for it. And so within this, I would also add in disability bias training. So too frequently, I think we're all kind of susceptible to making assumptions about our patients that can impact how we think about them, how we care for them, which may not be true because we see them when they're sick and in the ICU and not at home, and not to the eyes that their families see them. We've also talked about primary palliative care. We've kind of mentioned that is akin to what a primary intensivist does. And then also mediation principles.
Anything else to add, Erin, to that?
No, I think it sounds amazing. And looking back to when our program started probably 8 years ago, but obviously is not standardized. It would be really nice to have had all of that and just seeing how maybe I would be more successful or less successful at, the primary intensivist role. Maybe I wouldn't have taken on so many patients at one given time had I known then what I know now. Because I think there's definitely a piece of distress that comes with the morbidity and mortality of our patients and their families.
Oh, definitely. I really appreciate the overview of the body of work so far. What do we consider the next big research questions of the area of primary intensivists in the PICU? How are we providing care to these patients and families?
I think the next thing is people to have the mindset of if they're doing it or they're planning on doing these or any other kind of novel interventions to improve family-centered care for the long-stay patients or anyone else, is that they collect the data of what they're doing and they share it. Because we really need more evidence to know if and how effective these interventions are. As we've mentioned, these interventions, there's associated distress, there's associated time and effort. I know there's places out there that are not doing it because of the worry of those things. And if we had more data about what it actually took, maybe some of those worries would be abated a little bit and more places would be willing to do it. So I think in general, we're still in our infancy of studying this, and that if people want to provide more and better care, and so I hope as they go about doing their great work, they're also taking the time to collect the data and share it.
Jeff, if you'd like to share, I think it'd be helpful to hear about your upcoming trial.
Well, again, it's very much only in the works, and it's the stage of hope, but we are preparing a application so that we can have a multi-center randomized trial of primary intensivists and primary nurses. There is limited evidence on the effectiveness of these things. I think we all agree that there's intuitively, they are good for patient-centered and family-centered care. But at the same time, a well-done trial could establish whether or not these interventions provide justifiable benefits to this vulnerable and growing population, and thus whether they should be more broadly implemented.
And Zach, just one thing to add, in critical care for a long time, there was very little evidence-based literature for us really to follow whatsoever. And we're becoming more evidence-based. But to me, this topic is so much experience-based. When I think about the families that I have cared for and the patients that I have cared for in life and loss, the benefits of having a primary intensivist seem exponential. And not necessarily thinking about length of stay or how long the breathing tube or if they had a DNR or not, but just that relationship and how well they felt their child was cared for and they were cared for some reason means something to me. And it gets me coming back to my job day in and day out. So I'd like to think of it, yes, we need some more evidence for sure. And I couldn't agree with Jeff more. And we will be very supportive of anything that he rolls out. But I would love just to have more patient-family input in the literature because I think that their words can be impactful to the physicians who are deciding to or not to take on a program such as this.
Mm-hmm. Something that needs to be captured with more personal, like words and statements.
Well, just the as Erin's the recognition that a hard or fast, if something does or does not reach a certain p-value, doesn't necessarily take away what these sorts of family team support interventions might be able to really offer.
Well, it's been so great hearing each of your perspectives on this, Jeff, with the experience of the literature and the scholarship and the maybe the next steps in research, and Erin with your bedside approach and all of your experience walking with these families and these patients in the cardiac ICU. Certainly, it's been really helpful to hear all of that. When I reflect on myself maybe 18 months ago coming into fellowship, this topic, long stay patients, it's not as exciting like sepsis and ARDS, but gosh, now at this point in training, it sure feels like every bit of, if not more important. And I really thank you for sharing everything that you have today about this topic with us and our listeners. As we move towards the end of today's conversation, is there anything else that you wanted to cover?
I would like to thank the two of you, Zach and Alice, for being willing to talk about this. I agree, this is not one of the more exciting topics that come up in our career, but I think it's a big part of what we do and will continue to be so.
And it may likely have just as much impact on a patient outcome as the antibiotics that you choose. And it's an incredible honor to be chosen by a family to take care of them and their child in the primary intensivist role, if that's the way that it should be or not. I just get such a sense of immediate family and, the ability to communicate with families that are just incredibly vulnerable. And for you to really influence their experience, I think it's just incredible as a learner. And still even being, 9 years into this, I feel so much like a learner. I learn every day from each and every one of these families. And I think the families of patients with complex medical conditions, they offer such incredible insight on just really the value of life and what that means to them. So I think this topic is awesome. I would love to thank Zach and Alice and Jeff for the work that he's doing and continues to do. So it's awesome.
Well, that sounds great. I appreciate the kind words. And this is another reminder that everything that we do at the bedside, not everything needs to be measured in p-values and confidence intervals. Sometimes that person, that patient, the family member just saying thank you can mean so much more. And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com or find us on Twitter @CritPeds and @PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review on your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.